Your Royal Highness, Excellencies, ladies and gentlemen, welcome back to this fabulous theatre, to another panel session, another report to consider. I'm Stephen Sacker, and our subject for the next hour and a half or so is nursing and midwifery, and as you see from the report, and I hope you've all got a copy, the key to the rapid and cost-effective expansion of high-quality universal health coverage. So the session right now is all about the potential in our nurses and midwives around the world. And for those of you who haven't seen me before during this WISH conference, I'm a journalist with the BBC, so I'm in many ways a layman when it comes to the healthcare professions. But just as somebody who has spent time in hospital quite recently with back surgery, I can speak from experience that the quality of our nurses matters enormously, and they do an amazing job. And the question before us is, if we are to deliver on all of the promises that have been discussed at this WISH conference, not least the grand ambition to extend universal healthcare, universal health coverage to 1 billion more people in the next 5 years, then tapping into and maximizing the talents and the potential of the world's nurses and midwives is absolutely central to that mission. I've learned quite a lot just in the last day or two as I prepared for this. I mean, just the facts and figures are amazing in themselves. There are, across the world, 23 million nurses and midwives. Half of all people who work in healthcare would fit within the description of nurses and midwives. So we're talking about an extraordinary number of people, the absolute core of health systems around the world. And of course, they bring with them a huge amount of talent and commitment. Today's discussion with this insightful and experienced panel is to discuss just how to maximize all of that. And it's an extraordinarily human question as well, because again, as I've just learned, 90% of the public's interactions with healthcare are with nurses. You know, perhaps the most high-profile people in any healthcare system are the talented doctors, the surgeons, the stars maybe, but perhaps we need to be moving away from that notion of hierarchies and stars. Perhaps at times that gets in the way. So we'll be talking about that too. So there's a great deal to discuss. I'm going to introduce you to my wonderful panel, and then we're going to hear an address, opening remarks from Lord Nigel Crisp, who, alongside Sharon Brownlee, who I'm going to introduce in just a moment, these two at this end of the panel have been instrumental in putting this together. And I do strongly recommend one more time that you all, if you haven't got a copy already, get hold of a copy, because it really is an important document, I think. So let's introduce our panel. Next to me, as I say, Lord Nigel Crisp. Now, he's co-chair of the UK All-Party Parliamentary Group on Global Health in the UK House of Lords. He's co-chair of the Nursing Now initiative, which is hugely important in many different countries around the world. He's got vast experience of running health systems, not least because he's a former chief executive of the English National Health Service, which is quite an onerous job, I would say. Next to Nigel is Professor Sharon Brownlee, who is Dean of the School of Nursing and Midwifery at the Aga Khan University, based in Nairobi, but Sharon works all over East Africa, and in previous incarnations has worked in many different countries, Australasia and further afield as well. And Sharon has been a key player in putting together this report. Next to Sharon is Dr. Matshidiso Moeti, who is the Regional Director for Africa for WHO, the World Health Organization, so welcome to you. Next to Dr. Moeti is Dr. Srinath Reddy, who is President of the Public Health Foundation in India, a cardiologist by training as Senior Advisor to the WHO, served on various international panels considering this very issue of how to best utilize the nursing profession. Next to Srinath is Basim Ode. He's a nursing affairs specialist here in Qatar with the Primary Healthcare Corporation. Basim, welcome to you. And at the end of our panel, I'm delighted to welcome also the Honourable Mr. Upendra Yadav, who is Deputy Prime Minister and Minister for Health in Nepal. So please give all of our panel a very, very warm welcome. Great to see you all. Let us kick off, if we may. I've been referring to this already, so let's get Nigel to give us some opening remarks, an overview of the sort of the key points and the conclusions from this nursing report. So Nigel, I'm going to say the floor is yours, and looking forward to hearing your opening thoughts.
Thank you very much indeed, Stephen. Your Royal Highness, Excellencies, ladies and gentlemen, it's a great pleasure to be presenting this report on behalf of my co-authors of Sharon Brownie here, but also, forgive me, Charlotte Refson, and it's very good to be presenting it on behalf of actually a nurse and a doctor. But as you'll see on the second slide here, I'm also presenting it on behalf of a wider team. I'm hoping I've got a second slide here that will come up. A much wider team of people who contributed to this. And can I say thank you to all of them who are here in the audience and elsewhere. And what you may see from that is that actually appropriately for a document on nursing and midwifery, more than half are women, more than half are nurses, but not all are nurses, and that's important. It's not just written by nurses. And what you won't see from that document is that 2 or 3 of them are actually young people. Under 35 is the definition I think we have used to make sure we're getting a whole range of different views into this report. Let me just also do a couple of other thank yous. Let me thank first of all the people at Wish for having us here, for enabling us to do this, but some of the people in the background, and if I just can mention very quickly, Dee Dee and Nicolette and Steve and Aphrodite and Newton and Nick and others who've played such a big part in helping us to get this organised and make it happen. But let me also say thank you to the great nursing champions. First of all, to Her Royal Highness, Princess Muna of Jordan, who for very many years has been a great champion of nursing around the world. And it's wonderful to see you here and to know that we've got your support as we launch this report. Let me also say thank you, though, to Sultana Afdal, who's the Chief Executive of Wish, who I think has become a real champion of nursing and has been a great support to us here as well. So really appreciate that, Sultana. And may I also finally just say thank you to Aradazi as well, who's, again, one of our champions. As a leading surgeon, he understands the role that nurses play and the role that nurses can play in the future. So really great to have all that support. Now, I have a terribly simple message, and it is the top one. I could almost stop having said that. You know, that's the message I want you to take away, that this is the key. If you are working in countries where you want to see universal health coverage spread, then actually the key, not the only thing, but the key to rapid, cost-effective and high-quality universal health coverage will be about developing and investing in nurses and midwives, and I'll tell you why in a moment. Let me say, however, this comes with a health warning, and I need to say this really very loudly at the start, I think. Health is a multidisciplinary activity. We want multidisciplinary teams. So we do absolutely recognise nurses work within a multidisciplinary team. Our argument is they're the biggest part of that team, and they are very often the most undervalued and underutilised, not able to work to their potential. But also, it's not a zero-sum game. If nurses are doing more, then the whole team benefits. It's not the nurses will be doing more at the expense of other people. So nurses, I believe, will play a bigger role. And the other thing I ought to just say, it's about nursing and midwifery, but most of what I'm going to be talking about is nursing, which is the bigger part of the two workforces. Okay, let me move on from there into the text a little bit. Just by way of context, we're talking about universal health coverage. You all know what that means. The discussion to date has very much focused on the left-hand side of this. Talked about finance and services and coverage. We've got to shift the debate down to the right-hand side, and particularly towards the workforce in general. As the great English Dr. Muir Gray said, healthcare is a human contact sport. You know, it's about people at the end of the day, and we've got to get some of the universal health coverage debate down to the right-hand end there as well. Let me then move on to nurses and why there is a major role for nurses in the future, perhaps even more than in the past. And I've got 3 points on here. The first one is that there is a changed burden of diseases. We all know about the development of non-communicable diseases and indeed aging populations with more comorbidities. And nurses with their sort of biopsychosocial view of the world as opposed to a pure biomedical view of the world are very good for providing the sort of care that those groups in the population need. Nurses are close to the community. They can provide person-centered and holistic models of care. They can do a lot more around health promotion, disease prevention and health literacy in the communities that they work and that they are part of. And they can help tackle some of the social determinants. It's not just about healthcare, it's also about public health here as well. And they're very often the first health professionals that people meet. They're often the gateways to hospitals and specialists, particularly in low and middle income countries. In Uganda, a figure I've been quoted is that there are 2,000 clinics in Uganda with only a nurse as the only professional there. They're the health professional people see. And this is again a very important point, community health workers are fantastically important, but actually if they get decent support supervision and are able to pass referrals to nurses, then the quality of what community health workers do can be enhanced and can be guaranteed. So there's a sort of tide, there's a lot of reasons here in the background why we need to pay more attention to nurses. Interestingly, there's a great deal of public support for nurses. We didn't realize this. You can see there are 4 quick questions we asked. First one, it doesn't matter whether it's a doctor or a nurse who treats me for a non-life-threatening condition, yes or no. Do you agree or not? I value nurses as equally important members of the healthcare team as doctors, yes or no? But how about these 2? How proud would you be, if at all, if your daughter chose nursing as a career? And how proud would you be, if at all, if your son did? You can see what we're trying to get at here. What's the narrative around nursing? We got some very interesting results. On the first one, the vast majority agreed strongly that strongly agreed that it doesn't matter who treats me, ranging from 63% to 80% in Malaysia. This is 7 countries, 6,500 people being interviewed. And 85% tended to agree that they valued nurses as equally important. So there's a lot of support out there. But what about the recruitment ones, which I think were interesting ones? And the results here are equally interesting. 82% said they'd be fairly proud or very proud if their daughter became a nurse. And that ranged from 66% in China to 92% in Thailand. I'm pleased to say we have somebody from Thailand on our Nursing Now board and Denmark. But interestingly, 70% said they'd be proud if their son became a nurse. We felt these were quite counterintuitive, actually, and maybe there's a changing narrative here about how people see nursing and how people understand nursing. Let me then move on to the practical steps that we can take. Let me turn to universal health coverage. We said rapid, we said cost-effective, and we said high quality. Well, the first point about rapid is you've got to develop the existing workforce. The WHO has made this commitment to 1 billion more people on universal health coverage within 5 years. You've got to do that with your existing workforce, and you've got to develop your existing workforce. And the existing workforce of 23 million nurses and midwives are able to if they were able to work to their full potential, then you'd have a really big impact. Because one of the big findings we found everywhere was nurses saying we're undervalued, we're invisible, we're not used to our full potential, we're not able to achieve what we're able to do, we're not able to work to the top of our license. These were the sort of stories we heard. And if we do more of that, we can have a big effect. Cost effective, well, again, we interviewed or looked at the research on both nurses and doctors, saw an awful lot of skills mix-match and task sharing, a lot of doctors saying they were doing things they didn't need to do, a lot of nurses saying they were doing things they didn't need to do and could do more. We also saw considerable cost savings and efficiency improvements from some of the examples I'll give you in a moment, and high quality. Generally, one of the things people talked about nurse-led services was this aspect of being patient-centered holistic care, and particularly appropriate, as I said earlier, for NCDs, for primary care and specialist nurses. A lot of research. Charlotte has done a great appendix that pulls it together that's not in this report, but it's referred to in this report. So Charlotte Refson's research appendix is available. So finally, let me then move on to just the practical examples, if you like. Where are the areas that we think, if you were trying to develop your universal health coverage, where would you really invest in the nursing aspect? There are other things to invest in. We'd say more nurse-led services, particularly for NCDs. We'd say in primary and community care, where actually they're already, in much of the world, the central person. Give them more authority and more ability to strengthen that role everywhere. Midwifery, child health and adolescent services, and a bigger role in prevention, promotion and health literacy. Some very practical examples, and our report is full of practical examples. But that is all very positive, but there are also some other issues that need to be addressed, and 3 other recommendations I'll draw your attention to. It's not always easy. You need to enact and implement supportive legislation and regulation. It's very important that the legislation and regulation enables your nurses to do things that they could do if you've got the legislation and regulation right. One quick example, recent law in Kenya said that many health facilities could not be run by nurses. This took us backwards as opposed to taking us forward. Really important point. Comprehensive workforce strategy, our second point here, that maximises the contribution of all professions. Everyone needs to be working at the top of their licence, not just nurses and doctors. And finally, raise the profile and status of nursing. And that takes me to my final slide, which is actually about the campaign that we are running globally, which I hope is on here. And here it is. 3-year campaign to end in 2020, Florence Nightingale's 200th birthday, running it in association with the ICN and WHO. My co-chair is in the audience, Sheila Clow from Botswana, and so is the president of the ICN, Annette Kennedy. Great to see you here. This started in February, and it's running to the end of 2020. There are already 111 groups in 64 countries. It is just spreading around the world virally. It's an extraordinary development, and without any money from us. And our focus in this is health for all, if you like, and universal health coverage. How can we enable nurses to make an even bigger impact on the world? So, simple message, rapid, cost-effective, high quality, or as I would put it another way, one of the biggest things we can do to improve health globally is to empower nurses. Thank you very much.
No, Nigel, thank you very, very much indeed. And it's a fascinating study with lots of positivity to it, which is terrific. And I want to pick up on that with you, Sharon, and we'll come back to you, Nigel, but I'm going to get down the panel and get everybody's thoughts on this. But Sharon, you intimately know this report because you're one of the people behind it. And it seems to be a message that is saying to all of us who are stakeholders in healthcare that nurses need to be given more responsibility, that they need to be given more autonomy, their talents need to be understood and utilized. But if I can ask some basic questions, are you saying that you foresee a future where all nurses are, across the world are, for example, university graduates? Should they all, in the future, in this world where they do more, they're used better and maximized, should they all, for example, have a degree?
Okay, thank you. That's a very searching question and one that's been much debated. My view is that most nurses should have a degree. But just as there are things that maybe the nurses can do that the doctors say that they shouldn't. There's also things that a fully qualified degree nurse doesn't need to be doing, can be supported by a less qualified, what we know as a second level nurse, or enrolled or community or practical or technical nurse, which should also, that qualification should have a clear pathway to enable those that then want to build and become a degree level nurse. So just as in a health system you should have community health workers, second level nurse, primarily degree qualified nurses able to have the leadership role, able to be able to coach those other layers of the health workforce, and also able to provide the leadership and guidance and the referral. But if I just give you a small example, so a nurse may be in a community clinic responsible for 2,000 or 3,000 people, is often the case in East Africa. A lot of the work needs to be done about community engagement, community buy-in on basic things like vaccination, contraception, healthy water use. All of those messages do not need to be delivered by a degree-registered nurse, but a degree-registered nurse can work with a cadre of community health workers, enrolled nurses and others. She provides the leadership, or he or she provides the leadership of best practice.
And do you foresee that, and it's interesting you're talking about gradations, a new sort of, in a sense, grade structure within the nursing profession.
Yes.
Do you see merits for international standardization? Because obviously on this panel we've got people from all over the world, in the audience we've got people from all over the world. Nurses have different training and operate to different systems in different parts of the world. Would it be useful if there was a much greater degree of international standardization?
Yes, and there has been many movements in that. For example, all the work done across Europe under the Bologna process standardised what it means to be a degree qualified nurse. There's also USA standards, many standards globally. So that then consistent standards allows two things. First of all, you know what a nurse is a nurse. That when you say you have a Bachelor of Nursing, what it means, what the skill sets are and what the competencies are. But even more important, it provides pathways for nurses to upgrade their skills, have international connections, best practice, so that they can then, with the qualification they have, know it's a consistent standard, be able to do a master's or a PhD, move to advanced and special practice, because everybody knows what that base is. So a lot of work has been done, but more would be good. And the ICN is one of the, and WHO standards exist that help benchmark that.
Right. Dr. Moiti, in Nigel's opening presentation, and I guess an underpinning of this entire debate is getting us all to, as Nigel put it, sort of accept and embrace the new narrative about the importance and status and potentiality that there is in nurses and nursing. In Africa, where you are regional director for the WHO, in Africa, do you think there needs to be a step change in the way populations, the public, looks at nurses and what they offer?
Yes, I do. As Nigel was speaking about being surprised at the support you found for nurses, I was thinking, if you ask people in rural areas in most African countries, you would definitely be assured that they do support the role of nurses, because the nurses are the backbone of the healthcare that they receive in most of the countries in the region, right up to the district level. And very often, even in districts, you may find in a hospital 1 or 2 doctors, and the people that are providing most of the healthcare in terms of outpatient services, nursing inpatients, are nurses. So I think what needs to shift is the perception at the policy level, within the profession, within ministries of health, within the councils that govern, the regulatory bodies that govern the practice of healthcare, among the doctors, among the nurses themselves, I believe, so that the policy frameworks, the legislation, the regulations that guide nurses' work and very much are supportive of exploiting, valuing, and optimizing the skills of nurses. Of course, among doctors as well.
Well, let me take that word you just used, valuing, in the most literal sense. Do you think part of the recognition of what nurses can offer and do is, frankly, paying them more?
Exactly.
And if that is an important part of this entire sort of initiative, that clearly has cost implications. You know, we're talking about trying to move to the next step of getting universal healthcare to the next billion, in a sense, the hardest billion to reach, the poor, the disadvantaged. But that sits perhaps uneasily with the notion that you pay nurses more, you raise the costs in your system at a time when you're actually trying to get the system to do more in terms of reaching more people. So how do we square that circle?
Yeah, I think valuing is also beyond remuneration. It's very much around recognizing and enabling. I think one of the issues is in a very traditional hierarchical setting, the understanding is that the nurses that take the doctor's instructions and execute, whereas we know that and I'll give in a minute the example of the national health system in Botswana, where I used to work as a physician, that we had nurses in different roles, including in leadership roles, as part of the policy making and as managers of institutions, of health clinics. When I was working as the head of the HIV/AIDS program in Botswana, my boss was a nurse, and that was absolutely normal, partly because we had very good nurse leaders, one of whom is in the room here, Sheila Klo, in my country, and we were a country with a very small population, without a medical school, with very few doctors, and nurses were very much leading the healthcare delivery. So I think valuing, recognizing, enabling, and giving nurses the space to exercise and use their skills is very much part of this.
I totally get that, but the more we're talking about, focusing on the skill set of nurses, and as Sharon says, pushing more and more of them through the degree program and the specialization programs. You're asking more of them, you're expecting more of them, and I guess, truthfully, they need to be rewarded for that.
Well, yes, I would say so. I think we have in Botswana, we have had, for example, nurses with degrees for a number of years. I think we were one of the first countries in the region to train nurses to degree level. Of course, the more qualified people are, whether they be nurses, doctors, architects, the more they expect in terms of remuneration. And this is
here's just a thought. I'll leave the topic in a moment, but do you think the pay gap around the world, not just in Africa, but around, do you think the pay gap and the assumption of a pay gap between doctors and skilled nurses is too wide?
I think we could. I'm not going to answer your question as asked, but I think that
Why not?
I think it's important.
Isn't it an interesting question?
No, I think it's important to value the skills based on the training that people have had, and based also on the role that they play. So I think that what needs to be done is to more fairly pay nurses for the training they've received, the skills that they have, and the services that they deliver.
Okay. Well, Srinath, you're smiling at me like I can't tell if that smile means you'd like to answer that question I just asked or not, but feel free to take it on.
No, I'll certainly be happy to answer the question. I think both the public financing side as well as society at large must weigh the benefits and the costs in terms of what nurses can deliver in terms of healthcare benefits versus what the costs would be if they did not deliver the services, particularly at the level of primary health care, and we had a lot of spillover into expensive secondary and tertiary care. Ultimately, it is that what matters in terms of saving the costs for the health system while providing a much larger array of benefits to the people at large, particularly focusing on primary health care, but even at the level of other levels as well. So, if we are really looking at the need for actually rewarding nurses for their larger societal role, we ought to do that. And in terms of the skill gap, there is no reason why we can't enhance their skills. So we need to enhance the skills, salaries, and social status of nurses, get the maximum value out of them.
Do you think, well, let me start with a more informational question. What is the ratio in India of doctors to nurses in your healthcare system?
Actually, it is much less than desired. We have a 2 million shortage of nurses at the moment.
But what percentage terms? What is the percentage of doctors as opposed to percentage of nurses?
Well, we have we have different levels of nurses. We have auxiliary nurse midwives who are school graduates. Then we have graduate nurses.
Yeah, but just
and
give me a
postgraduate
ballpark.
nurses.
I'll tell you why I'm asking, because I gather, I may be wrong, but you have an unusually high ratio of doctors to nurses, and I wonder whether you need to evolve your system to make it more efficient.
You're absolutely right. I mean, the nurse-to-doctor ratio is somewhere about 1.4. That is absolutely unacceptable. So we ought to have many more nurses, certainly. There's no doubt about it. And they ought to be also technology-enabled. In fact, just yesterday, at the American Heart Association meeting, my colleagues from the Public Health Foundation of India presented a very well-received study in which auxiliary nurse midwives with a tablet-held device, a handheld tablet with decision support systems, could very effectively manage hypertension and diabetes in the state of Himachal Pradesh, which is a hilly state. And the benefits in terms of systolic blood pressure reduction and blood sugar reduction lasted for 18 months of observation in the trial. And this has now been completely scaled up across the state of Tripura, which again has difficult access areas. So the feeling that the nurses are stuck in a groove and that there is a huge skill gap, I think is unrealistic.
How do you change it? You know, Nigel talks about the narrative. How do you change the narrative in India to boost the idea that nurses can do an awful lot of things, including things that doctors have traditionally done? They should be allowed, they should be given the autonomy and the responsibility. And doctors, frankly, need to learn to trust and appreciate and give responsibility to their nurses much more. How does that change? How do you do it?
I think we have to demonstrate, particularly when we're moving towards a primary healthcare-led universal health coverage system, and there are huge access gaps and affordability issues. Demonstrating very clearly that the nurses can actually deliver many of these services in a dependable and provide chronic care, continuous care as well in primary health care. I think that's going to be the real game changer in terms of providing the evidence and persuading both policymakers and the health professionals to change their attitudes at the moment.
Do you think that doctors, I'm not really picking on India particularly, but as you know the Indian system very well, I'll ask you, are too sort of protective of their status, their turf, their territory, and are loath to let activities go to the nursing profession because they somehow feel it might be a threat to them and their current status and position?
It is absolutely true, though it's not the right thing to do. But let me say about how we can change the situation and how we are trying to change the situation. There are 3 levels that we are really looking at. One is role of nurses in service provision. Then the second is the role of nurses in public health management. And third, the role of nurses even as knowledge generators, as researchers. Now, we have not recognized that nurses can play all of these roles. Service provision, I've already mentioned how these auxiliary nurse midwives and nurses can provide much better services, even with their current skill sets, but certainly when being technology enabled, they can actually do wonders. In terms of public health management, we have opened our courses both at the diploma level as well as the Masters in Public Health level and even at the PhD level to a large number of nurses so that they can actually become health system managers as well as researchers. And once they start doing that, the rest of the medical profession, health profession, will start respecting them. These false hierarchies will get dismantled. Once they see nurses managing health systems, once they see nurses contributing as research leaders, I think that is the way to go.
Yeah, interesting phrase about false hierarchies. Bassem, looking at, you've worked in various Gulf countries, you're obviously now in Qatar. Do you see false hierarchies here?
Yes, first of all, let me just add a few things to my colleagues, what they have just mentioned. I've been, attracted with the terms that's been used in nursing empowerment. Let me share with you 2 stories from the Middle East here, a story of success in Jordan and a story of success in Qatar. So nurses in Jordan, or a nurse, a few years back, one of the nurses of background nursing was a minister of something in Jordan, Dr. Ruwaida Maita. She's a nurse, and she used to be dean of my college. So this is a success story that will be recorded for Jordan.
Yeah.
A success story here for Qatar as well. All my colleagues, they mention something about nursing graduates, number of graduates in the market, etc., etc. We did not look at the market needs. What the market needs? The market is oversaturated with the nurses of general nursing or medical surgical nurses. We are in a huge or a big shortage of community health nurses. So we need to direct our legislative system, educational system in our countries toward creating or customizing the curriculums or the education in our colleges toward the community health nursing.
Why do you think at the moment, nurses tend to gravitate more to the general, the surgical nursing, rather than community and primary care nursing.
Yeah, looking at how many colleges in Middle East, I'm talking about the Middle East and GCC, how many colleges, nursing colleges graduate has a branch of community health nurses. Few of them, not that much. So the branches is not existing, the curriculum is not existing. The success story I can recall here in Qatar, in Calgary University of Qatar, they created a branch in the college to graduate community health nurses, because we need a community health nurses. Primary health care, the place that I'm working on, and we've got 26 health centers, community health care nurses needed there. So this is what Calgary did. They really studied the market, what the market needs, and they customized their business toward that, to achieve that. So we've got a saturation, oversaturation of nurses, for example, in Jordan, in some countries in the Middle East, in Egypt, and so on and so forth. We've got unemployed nurses here. Okay, we've got gender unemployed. Looking at the male nurses, we've got really high percentage of males.
In the Arab world, is it a very heavily gender-biased profession toward women? I mean, I don't know. What is the balance of men, women in nursing in the countries you've worked in?
If you ask me 20 years back, I could answer a different answer. Now it's different. 20 years back, in Middle East and Arab world, they were looking at the nurses, male nurses, not that much acceptable in the community.
Yeah.
Okay, like let's say it in another way, a shame culture that a male should not be nurses, etc., etc. The governments they were working on easing this concept that nurses could be male and female. We need the males, we need the females. Nursing is very honorable job, and we need gender from two genders. So they start working with that. In some countries like Jordan, they really encourage and support the education in the colleges, and they minimize the tuition fees to the middle, I think to the half of it, to encourage the nurses, males and females, to enroll in those colleges. And in 2001, it was a shock, actually, and a surprise that the number of male nurses tripled. Imagine that. And now in Qatar, they are now working on, in Calgary, they are working on enhancing or marketing the nursing profession among males to increase the number of males and so on and so forth.
Right.
So things are changing in the Middle East.
Yeah, okay.
Yeah.
Minister from Nepal, we'd love to hear the Nepali perspective and how it works in your country right now. You know, Nigel has given such a clear presentation on how nurses have so much potential within their training, within their skill set to do more. And for UHC to be delivered, they need to do more. Their utility needs to be maximized. Are you maximizing it in Nepal right now?
Yes.
Oh, well, that's good.
Yes, in Nepal. In Nepal, what happened, there is in primary level training centers and universities, medical university, colleges are there where they are graduating and their educations, and after that they are serving their own. We have the medical college, nursing college, where the trainings, the nursing educations, they are getting there. And in Nepal, in both sectors, private sector also, and in public sector. In public sector, near about 30,000 nurses are working in our remote areas also, in urban areas also. And more than 30,000, they are involved in private sector, and they are working there. So this is not a sufficient, but we have the vital role of the nurses.
Did you have the issue that Srinath was talking about in India, where at the moment the balance between doctors and nurses isn't quite right, and you know there are arguably too many doctors in percentage terms compared to nurses, and the doctors protect their turf in a way that isn't helpful?
No, we can't compare with the India. India is a very vast and developed country in comparison to the Nepal. But
It's not so much about size or anything, it's about culture. It's about
yeah,
the culture.
The cultural similarity is there. We have the cultural similarities. But we don't have still now, sufficient number of specialized nurses that we are trying to achieve.
Okay, I'm going to throw it open to everybody because I know there's a huge amount of experience in our theatre and I want you to ask questions of our panel, but I've just got a couple more questions that have come into my head as we've been talking. One is about how far you push the, I don't know if the powers is the right word, but the capacities of nurses to do certain things. For example, prescribing drugs, to become prescribing nurses. Now, in the UK, nurses can prescribe. It's been, in the past, quite a controversial area, whether that was a good or a bad thing to move to. So I want you, panelists, to tell me whether you think it is an important thing which needs to be internationalized.
Well, I was chief executive of the NHS when we introduced prescribing, and it was an interesting object lesson in what happens, in that in 2003, a number of doctors were advocating very strongly that they wanted nurses to be able to prescribe, and a number were advocating very
some
negatively.
are very loud. It's saying this is a terrible idea. Yeah.
Eventually, with the support of the politicians, because let's be clear, this is not purely a clinical issue, this is also how politicians behave, and how in that case Tony Blair behaved as Prime Minister, we took it through very carefully. And it was an issue in 2003. Today it's not an issue. I don't think British doctors see it as an issue. It's just something that is now part of the system. So I think, these things can be managed, and I think that's the sort of change that we're talking about. But can I make another very important point? In what we're saying here, and in the Nursing Now campaign, we're trying very hard not to be what I'd call colonial, not trying to say, this is what happens in the UK or America, or export the sort of French model of nursing or anything like that. Actually, what happens locally needs to be determined locally in terms of the local culture, the local geography, the local resources, and so on. So people will make different decisions around that.
Well, therefore, I'd like to throw it open to everybody. Who's got a perspective on this prescribing issue?
Yeah. Actually, it's not an issue here in Qatar. We started having this. We started having our school nurses prescribing medications, ordering medications in school settings. We've trained them. We changed the policy, the local policy in that. And now we are in the process of having or creating something called nurse vaccinators. So they can vaccinate, they can administer, order and vaccinate patients, clients, stable ones. This is what we call it empowerment for the nurses. Nurses, they can do that.
Right.
Yeah.
Dr. Moetzi?
Yeah, if I can add to that, if I can give the example of Botswana and many other mainly East and Southern African countries at the height of the HIV epidemic, when there were attempts to scale up access to treatment, we provided through, again, obtaining the agreement of the nursing councils, the medical councils, the ministries, for nurses to initiate antiretroviral therapy. Initially, this was viewed as something that's impossible to do, but it happens. And as I said before, in many circumstances in African countries, if you go to peripheral clinics, rural clinics, including in outpatient clinics in urban areas, nurses do prescribe because the doctors simply are not there. And what needs to happen is for the regulations to follow this. In addition to that, in some countries, we've had nurses trained to provide anesthetic services, for example. There's a strong push now in the African region anyway to improve access to basic surgical services, which requires anesthetists. In a country like Botswana, many years ago, we had nurses trained in anesthetic skills who were all over the district hospital. So this is absolutely possible to do, even beyond simply prescribing medication.
Right. Well, it's interesting what you just said about the reality of rural clinics across much of Africa, because it raises my second question. Then I'm going to shut up and let everybody else have a go. But my second question is this. Your presentation, Nigel, included some interesting, very positive figures on the degree to which the public say they're not bothered about whether they are dealing with a nurse or a doctor in the first instance. Do you think we need, again, not being geographical about it, but generally internationally, we get to a point where a lot of primary care interaction between potential patient and the healthcare service is actually nurse-led, and that there will be lots and lots of clinics in rural areas, but in urban areas too, where there aren't any doctors at all, where doctors aren't present and where nurses at a senior level are running the whole show.
2 quick points. Yes, I think there's a very big... but the first point is, actually, we haven't invented this. We're pointing at what's already happening. There is change happening around the world, as we've already said. There's examples here. I was called for a checkup by my primary care team the other day, and it said, did I want to see a doctor or a nurse? You know, it was
Which box did you tick?
Well, the nurse, of course.
I suspected you weren't going to say anything else, but yeah, we are believing you. So
absolutely. But you know, it is starting to shift the way that people are thinking about this, and we need to start changing. As I used the expression earlier, the sort of the narrative in a way. But also support it, because I thought what Dr. Moeti said was really interesting. Nurses were doing it, and now we've got to get the regulation to help make sure that they're, in a sense, doing it legally and with good quality controls.
You've got to get the governance system to catch up with reality in a way.
And may I just add something, that it's important to emphasize this isn't second-class treatment because doctors aren't there. Because there's evidence.
Although some people will perhaps think that, despite all these surveys, some people
I think
will.
this needs to be strongly emphasized, because there's evidence to show that in providing clinical services, if you look at the outcomes, in some cases, you will find outcomes that are just as good if a nurse who has been appropriately trained, who is supported as a physician. For example, when I was in charge of the TB program in Botswana at a certain moment in time, where there are clear protocols that define what you need to do, we had huge problems with doctors wanting to experiment with this and that, and nurses being able to absolutely follow the protocol and have very good outcomes. I believe there is data to show that if people are trained, they have an algorithm, they have a protocol to use, the outcomes in terms of services provided, clinical services by nurses, can be as good as for doctors. So it's important to emphasize this is a way of using the capacities that exist in countries, as opposed to having some sort of, we don't have any other choice, this is a second-class service. So we need to think about the competencies that are required to deliver a certain type of service within a team of doctors and nurses.
I'm beginning to think the subtitle of this panel should be "Who Needs Doctors?" But that would maybe be taking it too far. Srinat, sorry, Sharon, and then Srinat.
I think there's some basic underlying principles that should be thought about. The issue is the patient at the middle, and then the issues of access, quality and safety. Early in 2000, I did some research in Australia that asked rural people in Australia, did they want to see a doctor? Did they want a GP, a physician assistant or a nurse? Universally, they came back and said what they wanted was access in a timely manner with a competent provider with dignity. So they wanted respectful care. So the question then becomes, when I get into this debate about doctors versus nurses, always remember there is more than enough work for everybody. There's such a huge ungap, a billion people that don't have care. Right? So there should be no debate. The issue that always comes back to the person, and if you've got 23 million nurses, who is then able to expend and scale up the access, and it requires enabling legislation, good training and respectful care. And the people won't say, I want a nurse or a doctor, as the research has shown.
Gotcha. Right, Srinat, quick comment, and then we're going to open it up to our audience.
Well, as Dr. Moeti said, there is enough evidence to show that nurses follow guidelines much better. There were standard management guidelines, which are absolutely critical for universal health coverage. In terms of appropriate care, I think you can depend a lot more on nurses than on doctors who tend to be a bit anarchist. But nevertheless, the other element is, I think, we must open avenues for interprofessional education.
Right.
Because healthcare is a teamwork. So we ought to have doctors and nurses training together, even as students, at least for part of the education. That brings the team spirit, but also develops mutual respect.
That's a very interesting point, yeah, good. And there's some great tweets coming in as well. I hope we're all reading them as we have this conversation. And do feel free to stick your hand up if you are indeed the chief nurse from Sierra Leone, because we're hearing about your views. Where are you? Would you like to contribute, ma'am, at this point? Well, I'll tell you what, number 2 microphone is heading your way, so let's hear your input.
Thank you. Thanks to the WISH team and to the panelists, especially Lord Nigel and Sharon. It's an interesting thing because to me, I think nursing is like a gender thing and the mindset of people thinking because you're a nurse, you're a woman, and people look at doctors because most of them are men, and they think because they're men, they are of a higher caliber, of a higher education, and they think they give the best health care. And if I borrow on Charlotte's quotation yesterday about equal say for all, equal say for all means in all dispensations, even politically. How do we look at nurses politically? What is the environment for nurses to be able to support the universal health coverage? We need the kind of environment. We need the recognition. We need the training. We need the type of education to make us at least be able to contribute to universal health coverage. Yeah. And if the environment is not there, I'm afraid it will be difficult for nurses to be able to operate very well.
Well, that's a really interesting point. I think, in terms of the politics of this, doctors have always said, I'm not trying to make it a doctors v nurses thing, but doctors have a strong political lobby, they have access to power in a way that perhaps the nursing profession traditionally has not. And it may be also, as we've just heard, a somewhat a gender thing as well. But do you think, when one considers this, because it is a political issue as much as anything, it's about the way governments react and who's got the government's ear, that nursing needs to be higher up the political agenda?
I do, yes. And it's perhaps also just worth remembering that Florence Nightingale was a wonderful political operator in terms of how she got nursing established in the first place. But I think it's fantastically important. But also, can I just come back to this doctor-nurse thing? It's not a zero-sum game, this. Nurses taking on a bigger set of responsibilities actually liberates everybody. And there's still a very important role for doctors. It is shifting, though, around that boundary. But I think politics is part of this. Politics and actually, of course, the communication, the media and the people who tell the stories and don't just pick up the sort of traditional stories about nurses and so on, but actually pick up some of these more unusual stories.
And Minister, as you are our politician, or at least our ministerial person on the panel, if you just think about your own country, do you think the voice of nurses gets heard properly in your country?
Yes, in our country, the nurses, their education, their trainings, where the government is providing them, and they are working in different levels, primary level, secondary and tertiary, all level, along with the doctors. And quality of training is essential to them to work. That is essential for our country.
Okay. Right, let's get more questions from the floor. So raise your arms. Good, we've got plenty of questions. Number 1, microphone. If you can go to the lady with the red... Oh, you're leaping off in a different direction.
Thank you.
All right, sir. And then, ma'am, we'll come to you with the red jacket. So stick your hand up again in a moment. Yes, sir.
Thank you for giving me the chance. My name is Ahmed. I'm from Egypt. I want to first add the 3rd success story after you in Jordan, and I appreciate the Jordanian Nursing Council. I believe in multidisciplinary activities and multidisciplinary working among nurses, physicians, and all the healthcare sector. But I have a dream that every country in the world have independent nursing council to make it more strong voice in the governmental, all the level, and all the health, not only the health sector, but all the sectors in political issue. My question, and I appreciate this, Highness Mona and Dr. Waida Maita. I already visited this one, and in Egypt we take this Inspire experience, and I invite all the countries that haven't nursing council that make even a simulation model to empower the novice nurses and the students to have a dream that maybe after 5 or 10 years, we have a separated independent council. My question regarding African novice nurse and the student, how can we empower the novice nurse and the student actively engaged in achieving Africa Agenda 2063 and as a general SDGs 2030? Thank you.
Right. So the role of nursing in delivering the SDGs is an interesting one. So we'll get to that. Let's take, I did promise the lady with the red jacket here, yeah.
Thank you. Annette Kennedy, President of the International Council of Nurses. And just to thank the panel and thank the co-authors and thank Lord Nigel for stimulating this debate. I'd just like to say that if you believe in human life and if you believe that health is important to everybody throughout the world, then you will have the right person in the right place at the right time with the right skills. And that doesn't matter whether it's a doctor or a nurse, it's the right person. And I don't think that we'll ever achieve universal health care or change the way that NCDs is growing without using nurses to their absolute maximum skills. And that's so important. So I think you have to change the debate from how much does it cost and how expensive is this or that to say, you know, health, an investment in health is an investment in the economy. And that's what you have to do. Great.
Well, the 2 points are obviously very much related, and the SDGs commit to sort of delivering decent healthcare for all. I'm paraphrasing, I can't quite remember the phraseology, but that's basically what it amounts to. And obviously all geared toward delivering this by 2030. And I think the point is that there's no way that can happen without nursing being a huge part of the story for the next decade and more.
I found this interesting as a non-nurse, and I've worked with nurses for many years, but it's only when I started to really get into this that I saw things slightly differently. And we interviewed, not for this report, but for an earlier report, nurses in 15 countries, and they all said, we feel, not universally, but we feel invisible, undervalued, we're not part of the system, we're not, and this relates to the point of the gentleman from Egypt, that they're not listened to, they're sort of taken for granted. And I think that's almost the biggest point in all of this, is actually that nurses can do more, as we say, and across all the SDGs, not just the health one, but on the environmental issues and so on. And I think what we're trying to do here is just expose that point, and I think people get it. I mean, we've had terrific support from WHO, seeing Jim in the front, Jim Campbell in the front row here, and Elizabeth Ero and others. And this is a sort of, there's no one size fits all to make this change happen. We need to get the leaders, the powerful leaders like the people in this room, to be talking about this, to be making something visible that's tended to be invisible.
But how far down that road do you think we are?
We're starting. We started our campaign in February. It's good to know that we've already had Norway and Sweden have both appointed chief nurses since then, and allegedly because of our campaign. It's quite interesting that people are starting to sort of see some movement happening. And it's happening differently in different places. What's not happening, and Dr. Moti and I were talking about it beforehand, is it's not getting joined up. It's not strategic. Dr. Moti was talking about lots of isolated good examples. How do we make it strategic? How do we make it visible? How do we make it big? And I think that's the tipping point we're on, actually, I think, Stephen.
No, well, thank you. And the tweets are coming in and comments which reflect some of the discussion we've been having already. But let's keep our voices as well as our social media feeds going. Number 5 microphone, there's you, sir. Yeah, I'm looking at you with your hand up. You have a go. Sorry, ma'am, not sir at all. What am I talking about? My eyes, I haven't got my glasses on. And then after that, we'll go to you, ma'am, with your hand up, looking energetic. No, go backwards, number 1. Go backwards, behind you. Number 1, behind you. Yes, up, yes, there you go. All right, so you first, ma'am.
All right, thank you. I am Lucen Kutumula. I am Deputy Director of Nursing and Midwifery Services in Malawi.
I really wanted to comment that I think we really spend a lot of energies discussing the rightful positions between doctors and nurses. And I don't think this is the argument that the community out there wants to see. The community out there wants to see outcomes that actually talk to their health. And I really agree with the previous speaker who was saying that it's the right person at the right time whom I can meet and, share my issues to.
Yeah.
I think that for nursing, we really have now to look at areas where we can make a very good impact in terms of health in the world. Instead of now all of us sitting at one place with the doctor and all of us trying to say, no, the patient is mine, no, the patient is yours, no, I don't think we need to do that. There's a lot of work that nurses can do out there that is sitting neglected. There's school health nursing. There's occupational health, which I think for my country is an area of priority as we talk now. And I think that's where we can actually do a lot of primary health care, sending a lot of clients to the doctors to be actually seen where they're supposed to be seen. But if we all just dwell in the words and just believe in this type of argument, which I think I've seen it a lot in most of the meetings that I've attended, it's like doctor, nurse, pull here, pull that. This will not actually benefit the communities that we are all serving. We need each other, we need to work as a team, we need to understand our scopes of practice, and we need to define what is it that I can do according to my regulation, what is it that the doctor is going to do according to their regulation. The nurse is not going to define the doctor, and the doctor is not going to define what the nurse is going to do. Their scope, through their regulatory bodies, must say exactly what they should be doing. Thank you very much.
Okay, well, I think your point echoes very much what we heard earlier. I think I ought to plead guilty. I've been sort of stirring the pot a little bit by suggesting there might be some turf wars between doctors and nurses. I planted the idea. I don't think the panel did. But I think we should address it. I mean, it's out there as an issue, and we heard that Srinath was saying, yes, in India, for example, doctors need to think hard about the way they've operated in the past. So I'm not sort of apologizing, but I take the point. We shouldn't couch it too much in terms of conflict. Oh, yes, I was going over there. You, Mum, yeah.
Thank you. First of all, I would like to thank the Qatar Foundation for providing us this WISH summit that's very interesting and informative. And then thank you all the panelists. I'm Farah from Iran. I'm the head of midwifery department. I would like to add something to these issues that have been mentioned. That the midwives, considering the role of midwives providing the preconception care and also prenatal care, childbirth, and also postnatal, and also providing the care during the reproductive age of the women, and their influence to the UHC, and increasing the UHC for the women and for the pregnancy. I would like to add this and mention that, would you please, I think that all the things are important, especially if you have considered the midwives beside the nurses, it would be more important. Thank you.
Right, thank you. I just want to, that raises an interesting question. Is it, going forward, are we going to see maybe a blurring of the lines between midwifery and nursing, in the sense that there might be a case for making nurses, many of them working on their own or in rural areas, totally I mean, they probably are already, but have midwifery skills, nursing skills, sort of maybe paramedical skills, all part of their training, so that they are sort of truly multi-skilled and multi-trained nurses.
Again, that's a very big debate between nurses and midwives. I think there's different models, what we've discussed. In high-density urban areas, the separation of nursing and midwifery only works very, very well. In some rural and remote areas, and one of the big things in Africa, but also parts of rural Australia, is that at times you need the nurse and the midwife in one place. So there's an re-emergence at the moment of degrees that are, rather than a 3-year degree, a 4-year degree where someone has a nursing licence and a midwifery licence, is fully competent to the scope of practice. And also emerging in Australia is someone that has a nursing licence and a paramedic licence. So in an Australian context, if a flying doctor goes out and there's one seat in the helicopter, shall I take the paramedic, shall I take the nurse, shall I take the nurse, shall I take the midwife? So they are developing the dual degrees where the person they take has both licence classes. In sub-Saharan Africa, one of the real scourges was that someone would go in trouble, arrive at a clinic and the nurse would say, sorry, I'm not a midwife. She's at the clinic that's 30 kilometres away. So again, the consultations that we've undertaken in East Africa are that they want for the rural areas and particularly the 4-year dual qualified nurses. And WHO have developed some pro forma curricula. They have a 3-year nursing curricula, a 4-year midwifery curricula, a 3-year midwifery curricula, and the 4-year dual curricula for that very reason.
And do you see that becoming more and more common, more commonplace? Dr. Moetsi.
I think it's already been said, if these curricula are available, then it's for each setting to see what's most appropriate for its needs. So what is the context and what would work best to be, I guess, efficient and cost-effective in a particular setting. But I would think that for rural areas, if you have people who have both nursing and midwifery skills, that's useful, where the numbers are not sufficient.
Yeah. Okay. Right, let's go. I think number 2's got people nearby, so let's get a microphone to you, sir. And we ought to go to this side soon. Yeah, how about the gentleman against the wall there? Yeah. So first, over here, whoever's got the microphone. Who's got the microphone at the moment? This gentleman. No, I thought you gave the microphone. Yes, there you go. Stand up.
Sorry. Hi. My name's Justin Burkett. I'm from the University of Calgary. I just have kind of a couple questions. I was really interested in the conversation that was started about sort of an international standardization of what really is a nurse. I think we really have, when you travel the world and you're feeling ill, the first thing you think about is I need to see a doctor, because you expect the doctor to, there's sort of a generalization that all the doctors are trained to a certain body of knowledge. I think that we have a problem in our own profession as nurses, of which I am, that there are so many different levels of nurses. Coming from Canada, healthcare aides identify as nurses. We have LPNs, we have RNs, now we have nurse practitioners, all valuable in their own skill sets, but I'm really interested to know, from a policy perspective, how we can really define globally what is a nurse, so that when people are going into hospitals and clinics, they know that exactly what they're getting. Secondly, sort of a question for Sir Crisp, or Lord Crisp, I'm not sure how to, what to call you, sir, is about the Nursing Now campaign, and specifically men in nursing. I'm sitting right behind an entire row of University of Calgary and Cato male nursing students here. And there's lots of male nurses in the world who are very passionate and excited about our profession. And I'm just wondering what the Nursing Now campaign is doing to give us greater voice. Thank you.
Okay. Well, you make a good point. We did do quite a lot on the standardization issue, but Sharon, you've thought about this. So the point from Canada is quite a simple one. When people say they're going to, or are told they're going to see a nurse around the world, do we need to reach a point where they will be able to assume a body of knowledge and training in the same way that they perhaps assume it about seeing a doctor pretty much anywhere in the world?
I think so, yes. And I think it's an issue of narrative and about imaging and branding again. When there is an issue of standardization, and that occurs in medicine, but we also know that if I want to see the doctor, I'm not seeing a graduate doctor, I'm probably seeing a qualified GP, or actually if it's something really bad, I need to go to the hospital and see an emergency doctor, or I need a specialist doctor. So there are all those cadres of doctor. So the same as we would have the cadres of nurse, there is for all your basic care, a degree qualified RE and then as a specialist nurse practitioner, or maybe I need to see the advanced nurse specialist that's a nurse in renal. And I think because we're at the beginning of the journey, those differentiations are not globally known in the marketplace. But it's a really good thing to emerge, because in a campaign like Nursing Now, it's some of the work that needs to be done. The same as people understand different cadres of doctors, they should understand at times different cadres of nurses in due course.
Yeah, and then Nigel, this issue of particularly sort of encouraging and acknowledging the very important role of males in the nursing profession. Is that part of your overall Nursing Now campaign?
It very much is, and by the way, Nigel is fine.
I quite like Sir Crisp. It sounded...
Sir Crisp, indeed, yeah. Listen, with a name like Crisp, you get all kinds of stuff. Yeah, I do think it's very important that we get men involved, and some of our campaign is about telling stories, you know, and showing examples of people doing things in different places. But the Nursing Now campaign, I ought to say we've got 2.5, 3 members of staff. You know, this is not a big campaign in terms of resources, and then 1 or 2 of us who are the non-executives. Barbara Stillwell, our executive director, is just over here waving her hand. So she's a third of our staff. So it's what happens locally. So that's why 2 weeks ago in South Korea, when they launched Nursing Now, they had 5,000 nurses in a stadium or theatre like this, and they had 50 senators. The Nursing Association was obviously more powerful than in Egypt, or perhaps as powerful as in Egypt, and got 50 senators there to be part of that. You know, it's actually what happens locally that's going to count, because it's the local context that counts. We can stand on a global stage, and we can try and shift global policy, but it's what you do locally, whether it's in Calgary or wherever it is, that is really important.
Yeah, I'm just interested, Minister, do you monitor the gender balance in your nursing profession? Do you know what it is?
Yeah, we have lots of female nurses there, and male nurses number is less than that one. But male nurse is also doing good, but the female nurse is serving better to the patients.
Sorry, I missed the last bit. Female nurses?
Serving better to the patients. They are serving better. They're providing better service to the patients in comparison to the male nurse.
I mean, you think in Nepal that female nurses are just better than male nurses?
They are female, they are doing better.
Right, well,
yeah,
that perhaps
Nepal,
is a controversial opinion.
Female nurses there.
Feel free to take that up with the Minister after the panel. I'm not sure we should pursue that for the rest of this panel. We haven't got many minutes left, but I've heard a few controversial views this week. That's certainly one of them. Let us move on. I haven't done the front row, so I'm going to ask the lady, can a microphone get to the lady in the blue jacket who's very kindly standing up for us?
And you mentioned the man at the end.
Oh, and I did mention the gentleman by the wall. So, ma'am, forgive me, I must keep a promise. So, you, sir, I promised you, and then no, keep the microphone, keep the microphone. Yep, we'll do 2 at once. You, sir. Give it a good slap and it'll be fine. There you go.
Thank you. Yeah, thank you. I am Francis Omaswa from
Put the mic really close to your mouth.
Francis Omaswa from Uganda. I am on the board of the Nursing Now global campaign, and it's really exciting to have this discussion taking place here. I've been stimulated to say something about the experience in Uganda of training comprehensive nurses, comprehensive enrolled nurse, comprehensive registered nurse. They are also university degree nurses. But the program to train comprehensive nurses was to provide a broad skill base. In clinical medicine, they can prescribe. In public health, health promotion, home visiting, as well as midwifery. So that is an example of a needs-based response developed at a country level to respond to the health workforce needs of the country. Of course, there are issues about this, but I think we should be flexible and make guidelines or recommendations of good practice which are at a level that countries can adapt depending on their local situations.
Okay, sir. Well, thank you very much for that input and that thought from Uganda. Yes, ma'am, we promised you, yeah.
Thank you. First, I'm from Jordan. I'm a member of the Jordanian Nursing Council, chaired by Her Royal Highness Princess Muna. I'm a member of the Nursing Now campaign also. The thing that I'm going just to say that let's talk about, the cost of the ill health and where are we now worldwide. Are we happy with the NCDs? The report just released actually in last September. Are we happy about it? Are we happy about, the number of the, mental health, people, having problem with mental health? We are not happy. So the traditional ways of thinking, I think, it has to stop. We have to start from up. We're talking about healthcare professionals. When we compare to ill health, the cost of, we have to talk about the investment in this group. Nurses, physicians, midwives, allied health services, pharmacists, and everybody together what we can do for the people-centered healthcare. And this is, I think, very important. We need the thing that, nurses, if we want, to just, to have the evidence of our outcomes, besides, what physicians, pharmacists are doing, I think we have to have more research and evidence in this area. The outcomes of your work, of every day, of every single procedure you're doing on not only the health outcomes, but also, like Annette said, on the economic growth of the country. When we talk about 23 million nurses all over the world, how much we put, money on them to get the degree or maybe the diploma or whatever. It's too much, not cost, it's investment in the human resources. And I'm so happy that Her Royal Highness also was actually a commissioner in the Commission for Investing in Health Workforce. We're talking about the health workforce as a whole. If we keep slicing everything, I don't think that, we will build the right healthcare services that we need. We have a challenge of the primary healthcare. Last month, we talked about the Astana, and you all know about the declaration. We need to have stronger investment in nurses and physicians because, the thing that we have to talk is about the patients, is about also the community and the healthy communities and patients.
Yeah.
So I'm so happy that, we have many comments about, bringing the whole group together. If we don't work together, I don't think that we can do that. The other thing for nurses also, we should not always put nurses, frame them in a corner, a nurse. I think you are a healthcare professional. For politics, you need other also skills, not only to work, within the hospitals or the primary care. You have to learn how to negotiate, how to communicate, and how to be very good in health diplomacy too. If you want to go up and up, we need more nurses at, the higher level, at the political level, as well as, more professional nurses at all levels, starting from the primary healthcare, hospitals, and other. Because many of us also talking about hospitals, surgery, more than talking about primary. We have to face reality. We are in big problem in this world from, the health point of view, I'm saying. So we have to prepare the soldiers to take over in the healthcare provider in this world to make it better, hopefully.
Thank you. Well, it's a great rallying cry, and a plea for integration and cooperation and seeing the healthcare sector in a truly holistic sort of way, which of course makes a great deal of sense. I can see more arms waving, but unfortunately I can also see a red light flashing telling me we're out of time. I've been so impressed with the engagement, level of engagement of the audience. As we go, I just want to hands up all of you in the audience who are actually in the nursing profession. Yeah, a huge number of you, which is partly why it's been such an engaging and passionate debate. And hands up, how many male nurses are there in the room? Yeah, quite a number. Well, you may want to talk to the minister. I have to wrap because we're out of time. It's been really passionate and engaging. I think the report's terrific and really important. Let me just end by saluting all of you for being a terrific audience, and I'm saluting the nursing profession as well. And I'm also asking you to give a big thanks and salute to our terrific panel. Panel, thank you very much indeed. Thank you all.